Good morning, good evening. My name is Baltica Cabieses, and I will be hosting this first webinar of the webinar series entitled Health of Migrants and Refugees, Catalyzing Research Evidence Exchange between Chile and New Zealand. It is my greatest pleasure to welcome all of you today to this exciting webinar series, which is the first series of 6 webinars that are aimed to create a robust and rich exchange of findings and methodological practice related to the health of migrants and refugees between Chile and Aotearoa, New Zealand. Chile and New Zealand, despite being on opposite sides of the Pacific Ocean, share several interesting similarities in terms of geography, agriculture, and natural resources, marine and environmental focus, and relatively small populations with long-lasting, stable democracies coming from decades of progressive policies. This webinar series is co-organized by the Center of Global Intercultural Health at Universidad del Desarrollo in Chile, which is also a WHO-PAHO collaborating center on capacity building for training and research in the health of migrants and refugees, and the Center for Migrant and Refugee Health Research at the Auckland University of Technology in New Zealand. This webinar series is also supported by multiple organizations and institutions, such as the Lancet Migration Latin American Hub, the Chilean Network of Research on Health and Migration, RECHISAM, and the New Zealand Policy Research Institute. In terms of healthcare systems, Chile and New Zealand share several notable distinctions and similarities. Chile has a dual public-private system. The public system, called FONASA, covers about 27% of the population. 75% of the population, while the private system, ISAPRES, serves higher-income individuals. New Zealand has a predominantly public system funded through general taxation. The government provides universal health care through the Ministry of Health and district health boards, now centralized under the Te Watu Ora New Health New Zealand. Chile spends around 9.3% of its GDP on healthcare, whereas New Zealand spends a slightly higher percentage, around 9.7%. Also, both countries are below the OECD average in per capita spending, but achieve relatively good health outcomes, and both countries aim for universal health coverage, though access and quality can vary by income and geography, to name a few factors or social determinants of health. Life expectancy is similar, with New Zealand slightly ahead, around 82 years versus 80 years in Chile. Infant mortality is lower in New Zealand, reflecting strong maternal and child health services. However, both countries face challenges with non-communicable diseases like diabetes and cardiovascular conditions. We will be starting today the first webinar of this webinar cycle. We are very excited, and we have wonderful panelists to join us to share their knowledge and experience in the topic. Today's webinar is entitled Drivers of Vaccine Access and Acceptance Among Migrant and Refugee Populations in New Zealand and Chile, Evidence-Based Lessons and Challenges. To start with this webinar, I will introduce you to Dr. Alexandra Obaj. Dear Alexandra, you're welcome to open your mic and video now. Alexandra is a social anthropologist with a Master in Gender Studies and a PhD in Social Anthropology. She is the Director of the Center of Global Intercultural Health at Universidad del Desarrollo in Chile. Dear Alexandra, welcome to this webinar session. We're very happy to have you today, and you have 12 to 15 minutes to share with us through your presentation, your experience and knowledge on this topic. The screen is all yours.
Thank you very much, Valtika. Thank you very much for this invitation, and thank you very much for having the motivation of doing this webinar. It's very, very exciting for us to share our research results with New Zealand and to see what are the joint points we have in this matter. So I'll start sharing my presentation. And there we are. And this presentation is titled Vaccine Hesitancy, Access and Acceptance in Chile, Research Findings Among Migrant and Refugee Population. Well, this is us. We are the Center of Intercultural Global Health at Universidad, Desarrollo in Chile. We are an interdisciplinary research center, and one of our main research areas is health of migrants and refugees. So we're going to start about discussing especially what has to do or what are the joint points between migration and vaccines. Well, first of all, as an introduction, we all know that vaccination remains one of the most cost-effective and impactful public health interventions, preventing an estimate of 2 to 3 million deaths each year, according to the World Health Organization. By protecting individuals across all age groups, vaccines drastically reduce the burden of disease, disability, and mortality worldwide. Despite these proven benefits, vaccine hesitancy has been on rise, particularly in the aftermath of the COVID-19 pandemic, which disrupted immunization service and fueled widespread misinformation. Although vaccine hesitancy, define this as the delay in acceptance or refusal of vaccination despite their availability, poses a serious threat to global health. It increases the risk of disease outbreaks, undermines decades of progress in disease control. It also exacerbates health disparities in vulnerable communities and places additional strains on already overburdened healthcare systems. Addressing this issue requires coordination efforts in education, policy, and community engagement to restore public trust in vaccines and ensure equitable access for all. Migrants, communities, and migrant population are also in the part of this problem we have right now about vaccination hesitance. So vaccination in migrant population is a crucial component of the global broader strategies to improve immunization coverage and protect public health. Despite this, limited research has focused especially on the unique challenges and needs of migrants regarding vaccine access and acceptance. In response to global health concerns, the World Health Organization launched the Immunization Agenda 2030, an ambitious strategy aiming to maximize the life-saving impacts of vaccines and prevent 50 million deaths over the next decade. Yet, emerging studies have highlighted troubling disparities, including disproportionality, high mortality rates, and lower vaccine support among migrant communities. These gaps point to systematic barriers such as language obstacles, limited healthcare access, lack of cultural appropriate information, and migration-related fears. Addressing these disparities is essential not only for protecting vulnerable population, but also for achieving the broader goals of global immunization and health equity. About migration in Latin America, and especially in Chile, it's important to show some of the flows of migration that we are experiencing right now. Latin America has experienced a significant increase in south-south migration in recent years, and Chile stands out as a key destination within regional trends. As of 2024, migrants represent 8.6% of the country's total population. This marks a dramatic demographic shift between 2017 and 2024. The migrant population more than doubled, representing an 105% increase over just 7 years. This rapid growth reflects broader global migration patterns, where increasing number of people are moving within the global south in search of safety, stability, and opportunities. As migration becomes a more defining feature of Latin American society, it brings both opportunity and challenges for public health system, social integration policies, and national development strategies. Here we have some data about the patterns of migration that are the most number now in Chile. And here in these slides, we can see some of data that shows the vulnerability that migrants community are experiencing in Chile, about poverty, but also about other indicators as housing and how people are or not have social and health insurance here in Chile, where we can see these data from 2013 until 2017, where you can see that migrant populations is the most numbers of people without insurance, health insurance in our country. Well, we carry out this qualitative study titled On Revealing Barriers and Triggers to Vaccination Post-COVID-19 Pandemic in Chile, Opportunities to Reduce Unequal Gaps in Coverage from a Social Determinants of Health Led. This study, the aim of the study was to understand vaccination hesitancy for multiple vaccination efforts deployed in the country, including COVID-19 and the National Immunization Plan Strategy. We developed a qualitative multi-case study, and this was conducted in the 3 large cities of Chile: Antofagasta in the north, desertic climate, and where are a lot of migrant communities there; Santiago, that is our capital city; and Osorno, that is a city in the south of Chile, where some migrant communities have been settled there for a couple of years. This is part of the sample, and this was a big sample of migrant and Chilean population, but for terms of this presentation, I'm talking about the migrants sample of this study. Well, some of the results of the study shows that, first of all, what are the general perceptions of the National Immunization Plan among migrants? What we can say of this is that international migrants in Chile generally hold positive perceptions of the country's national immunization plan, often described it as stronger and more reliable than those in their countries of origin. Many participants emphasize that Chile vaccination program is not only comprehensive, but also more accessible, especially when compared to other Latin American countries. This favorable view is often shaped by migrants' previous experience with limited vaccine availability and overstretched healthcare systems in their home countries. Interviewers frequently point out that in their place of origin, vaccines were either difficult to obtain or inconsistently distributed due to systematic resource constraints. In contrast, Chile's structured and widely available immunization service have contributed to a greater sense of trust and security regarding public health among migrant communities. Here we have the side of one of the interviewers. There in Peru, almost no one has insurance, but there they do. Here they vaccinate everyone, whether Chilean or foreign, everyone, if they have to, even if you don't have a visa, even if you are illegal, that's what they say, it doesn't matter, we'll vaccinate you anyway, and that's good. In the context of increasing international mobility, there has been a heightened focus on border control and public health informants, often accompanied by the perceptions that migrants are carriers of disease. The reemergence of certain illness in host countries has, in some cases, been attributed, rightly or wrongly, of course, to migrant populations, fueling fear and suspicion. this narrative has contributed to stigmatization, with migrants sometimes being unfairly blamed for public health challenges. This was very notable and explicit through COVID-19 pandemic, where migrants experienced a lot of xenophobia in this aspect, as they explicitly note this in the results of the study. As a result, many migrants report experiencing discrimination and xenophobia, particularly in relation to healthcare access and vaccination campaigns. These perceptions not only deepen social divisions, but can also deter migrant communities from seeking timely medical care or practicing an immunization programs, ultimately undermine broader public efforts. Well, so what are the main barriers to vaccination access for migrants in Chile that we could describe upon the results of this study? First of all, lack of familiarity with the Chilean healthcare system among migrant communities. Second, limited information about vaccine administrations in the country of origin or during transit. Also, delay in initiation of antenatal care for those who were women that were carrying a baby. Administrative barriers to accessing healthcare services, also experience of discrimination and xenophobia, as we were describing before, and also transitions to the private healthcare system in search of respectful treatment, which also carries a lot of money charged for migrant communities. One of our interviews says, "When I was pregnant, it depends on the person and was assigned to see whether I was treated. Sometimes they would see me, but other times I would get a person who would say no, ask for my papers, and put up 1,000 obstacles not to accepting me while I was pregnant, feeling unwell." Also, a lack of an online system was reported by the interviewers. Experience of migrants, individuals who express frustration over the lack of digital vaccination registry, relying instead slowly on physical vaccination cards. And many people, for example, a Venezuelan woman was vaccinating her child in both Venezuela and Colombia. Upon arriving in Chile, she had records of all vaccines which were transferred to the physical vaccination card. However, she later lost the card, and there was no digital platform where the records had been stored. There are also parallel vaccination records linked to different identity documents which are not integrated. So this is a very, very talked barrier by our interviews. Thank you, Bentica. I'm finishing. Well, some facilitators that were also identified by our other interviewers is for migrant women being included in this study, universal access to healthcare without the need for a provisional national ID number was highly asked or highly reported as a key enabler of vaccination during pregnancy. And also this allows them to vaccination program. So about final thoughts. As in general population, distrust in vaccines has grown among migrants in the wake of the COVID-19 pandemic, reflecting a broader global trend. However, this skepticism often coexists with the general positive perception of Chile's vaccination system, which many migrants view as well organized and more accessible than their own countries of origin. These contrasting views highlight the complexity of vaccine attitudes and the urgent need the full inclusion of migrants within the national immunization plan. Addressing systematic barriers such as language, legal status, and access to cultural sensitive care is essential to ensure equitable health outcomes. At the same time, mainstream discrimination and particularly xenophobia continue to be widespread and openly acknowledged by migrant communities. Tackling these issues is not only a matter of social justice, but also a critical step in strengthening public health for all. These are some of the programs that we have in our research center that aims to bring some support to migrants in healthcare system and also in the vaccination system. And well, thank you very much for this time and for listening for this presentation.
Thanks so much, Alexandra, for that really interesting research around vaccination among migrants and locals, and particularly the capacity of sharing their own experiences, perceived barriers and facilitators for adequate uptake, as well as a number of administrative challenges that we have in healthcare systems among migrants' records in many topics, including vaccination. Thank you very much. Now I will give the floor to Nadia Tarania. Dr. Nadia Tarania is an associate professor of public health at Auckland University of Technology, based in Auckland, New Zealand. Her research program is dedicated to addressing health inequities experienced by marginalized populations, with a particular focus on migrant and refugee background communities. Through community-engaged approaches, she aims to inform equitable health policies and improve access to health services and for underserved groups. Dear Nadia, it's such a pleasure to have you with us today. Thank you for your time and sharing with us your presentation. You have, similar to Alexandra, between 12 to 15 minutes, and I will let you know when you are around the end of the time. Thank you very much, and the screen is yours.
Kia ora. Thank you so much for that warm welcome. And thank you so much for having me here today, and to all of you for joining. I know everyone's really busy, so we really appreciate you being here. So as Baltika said, my name is Nadia, and I'm really excited to be talking a little bit about vaccine access and acceptance in Aotearoa, New Zealand. So just very briefly, in Aotearoa, we do an introduction of Koaiao, which is basically, who am I? And so I just wanted to say very briefly, I'm originally from Canada and did some research with pandemic planning and First Nations communities. But I then migrated to Aotearoa about 10 years ago, and that really sparked an interest in what I can do from a research perspective to improve the health and well-being of migrant communities. So that's kind of what sparked some of my interest in this particular area. So just high level in terms of the migration context in Aotearoa and New Zealand, we've generally had a net inward migration trend, with migrants now making up about a quarter of our total population. So migrants arrive on various pathways for work or study, and we also have main pathways within which we accept refugees. So we have a quota program, we have a family reunification one, also a refugee and protected status one for asylum seekers. And we also have a community organization refugee sponsorship category, in addition to some one-off humanitarian intakes responding to what's going on in the geopolitical climate. So in terms of global inequities among migrants and refugees compared to their host population, as has already been discussed, there is generally what we're seeing in the literature, a higher burden of vaccine preventable diseases amongst our migrant populations in comparison to our non-migrant populations. And we've seen that migrants are involved in infectious disease outbreaks, particularly in places where they're living in temporary shelters and refugee camps. So what does this mean in terms of our immunization rates, as we know that that's an important aspect of vaccine preventable disease burden? So we did a scoping review and found that of most of the studies that looked at vaccine coverage, most of the studies reported a lower vaccination coverage rate amongst migrant populations compared to the non-migrant populations. And this has been found in another couple of studies in the European region and also in the MENA region. So when we look at the literature globally, there's a lot of factors that influence vaccine access and acceptance among migrant populations. So these, whether they be practical, legal, or administrative, are substantial and have been well documented. And these will include things like direct barriers, including costs, indirect costs of like taking time off work, and so on. So I wanted to spend a bit more time talking about the context in Aotearoa and New Zealand. So in New Zealand, all children are entitled to publicly funded vaccines, no matter their immigration status. And despite our efforts, though, unfortunately, as you can see, our national coverage rates have been suboptimal. We have not quite hit our 95% national target rate for 24-month-olds. So currently, it is improving. So we are up to 82%, which is really encouraging. As you can see, we took quite a dip after the COVID-19 pandemic and are doing quite a bit of work in this space. Now, in addition to our coverage rates being suboptimal, what's been really concerning for us is that our coverage rates are inequitable by ethnicity and also by geographic region. And this has been well documented. But what I became really curious about was what would these rates look like? And are there any inequities by migration background, given what we've seen globally? So that's really what my research program sought to look at. So we did a couple of national retrospective cohort studies, and we have a really fantastic data infrastructure here in Aotearoa where we can use the integrated data infrastructure, and it links various government and health and immigration data sets together. So we were able to link migration background with their immunization data. So, what we found with our overseas born children, so these are children born overseas who then arrive in New Zealand on refugee visas for this particular study, we actually found that not all of them were enrolled on our national register. Now, this is concerning because we don't actually know about these children and what their vaccination status would be. For the ones that were enrolled on our national immunization register, less than 1/3 of them were age appropriately vaccinated for MMR, and we found a similar pattern for pertussis. Now, once again, this was just recorded vaccination status. It may not represent genuine vaccination status, but we're only as good as our data. So this is what has been recorded for our overseas born children. So that made us then think about, well, what happens for the children who are born in Aotearoa, New Zealand, but have migrant parents? So we looked at our New Zealand born children, and no surprise, almost all of these children were on our national register, which makes sense because they're born here in Aotearoa and they're given a health ID number and go almost directly right into our immunization register. What we found what was really interesting, though, is our New Zealand born children of migrant parents actually had higher vaccination rates for MMR, pertussis, and HPV compared to our children of non-migrant parents. When we did some further analyses, we also found some other interesting things amongst the cohort of migrant background children. And this is, for example, we found that children of recent migrants, so their parents having migrated more recent, they had higher vaccination rates compared to those who had parents who had settled in Aotearoa for a longer period of time. We also found some differences by visa group and region of nationality, which was really fascinating. We also then did a study looking at vaccine preventable disease burden, so the related hospitalizations. And once again, we found really interesting results. So our New Zealand born non-migrant children actually had the highest VPD-related hospitalization rates compared to our migrant background children. So really what this was telling us is that it's so important to disaggregate our data according to migration background to really understand what is going on in terms of migrant and refugee health in Aotearoa, New Zealand. So we went on to then do some qualitative research, and it really pointed to some of those specific challenges that some of these migrant and refugee background caregivers and families were facing when they were navigating their health system in Aotearoa. So for instance, migrant mothers displayed limited awareness of services available, which echoes what we heard in the first presentation. So one participant said, it was an Indian migrant mother, she said, I had a pretty hard time finding a good midwife because I was pregnant for the first time. I didn't know anything, and New Zealand is a new country. I didn't have anyone, didn't know anyone, and had no family and no friends. Another really interesting finding was the transnational ties that they kept. So they had these really amazing social networks and would share information, particularly about health and immunizations, with their friends and family in their home countries. And this information sharing did seem to have the potential to influence vaccine perceptions and potentially even vaccine behaviors. So I think that will be a really interesting aspect to explore further. Mothers also discussed how many of their questions and concerns about immunizations and post vaccine management went unanswered, mostly due to language barriers. So, as one Chinese migrant mother said, due to the language barriers, I have this feeling of uncertainty. I am concerned that what if I cannot understand what the doctor says? The mothers also stressed that it was really important about who vaccinates their child and how the vaccines are administered. The stories really indicated that it was so much about the vaccination experience and how this was heavily dependent on the relationship with the provider and the overall health setting. So, as one young refugee background mother said, she, the nurse, vaccinated my baby, and that's all. And she was like, "Oh, you're done for the day." And I didn't know what she was getting. And as a parent, I wanted to know. So, really, to kind of support our families with how they might be feeling during these experiences. So, where to from here? What are some of the strategies that we can do to improve vaccine uptake and reduce VPD burden? So, we did a scoping review looking at interventions to specifically reduce VPD burden and increase vaccination rates amongst migrants and refugees. And we found 70 studies met our inclusion criteria. Now, they all looked at different outcome measures, which makes it a bit hard to standardize across all of the studies. But what we did find is that there were different levels of where the intervention was targeted, which makes sense when we think about the different levels of where we can influence. So, some of the interventions were at the individual level to facilitate uptake of health services. Some were at the community level to raise awareness and education. Some are at the provider level to offer health services in relation to treatment, screening, vaccination. And other were at the system level to increase compliance with recommendations. So these would be guidelines, policies, and regulations. The really important thing we found was that to be effective, these interventions had to overcome some of those commonly identified barriers that we discussed, such as language, culture, distance, cost. But what was really interesting is that there was a real focus on engagement with the community. It was so important to engage the community and organizations in co designing these interventions to ensure they addressed migrant specific needs. We were really recognizing the heterogeneity within and between our migrant and refugee population. So it was really important to engage the community in this. Some of the other research, we also talked to providers from their perspective. What do they think we can do to improve vaccination services or immunization service delivery for our refugee background children? And I don't have time to go through all of them, but I just wanted to highlight the four main areas that they came up with. So within overcoming linguistic and cultural barriers, they talked about access to interpreters and resources. Under health promotion and education, how can we effectively use media, social media, other resources, community events to support awareness? In terms of reducing access barriers, maybe that's clinics that have later opening times or open on weekends to accommodate busy working families, and time, cost, and information system efficiencies. There was a lot of suggestions about how to improve and streamline information sharing of vaccination records and so on between the services that migrant and refugee families would be engaging with. So, just to summarize, these were some of the findings that came out of the overall program. So, just starting at the caregiver level, as I said, it was really important who vaccinates the child and how, and the importance of really supporting informed vaccine decision making amongst our families. And importantly, trying to make those experiences really positive for them. At the provider level, it was building awareness about the diverse migrant and refugee experiences and the challenges that they might be facing. How can we improve access to vaccine resources to support informed decision making and deliver culturally safe care? building those trusting relationships and really focusing on the whole immunization experience, from the phone call to book the appointment to the receptionist that welcomes you and so on. And specifically looking at ways to identify and engage our overseas born children and adolescents. That was really important, because if we're actually not engaging with them and they're not on our immunization register, we don't know we don't have an accurate picture of our vaccination status. So that would be particularly important. And then at the system level, as I said, we did find some differences and inequities depending on the visa group within which the children were entering on. And so this creates an opportunity for us to put policies in place so we're not creating those inequities with the policies that we have. Reducing access barriers and increase funding and improving the infrastructure. And importantly, how are we collecting and reporting coverage data by migration background? But we need to be really careful about this to not further stigmatize a population that might already be facing stigma. So thank you very much for your time and for listening. I really appreciate it. And over to you, Baltika.
Thank you so much, dear Nadia, for this very comprehensive and exciting presentation. I most enjoyed it. Also by the combination of different methodologies and how both presentations raise the relevance of qualitative research to bring meanings to experiences and perceptions. That's really valuable within and across the Pacific research. Thank you so much.
Thank
We
you.
will move on now to the comments section, which will be conducted by three excellent panelists. We will invite first to the screen to Francisca Besani. She is part of the CESGI team in Chile at UDD. Francisca is a social anthropologist and a master's in public health, and she's a researcher at the Center of Global Intercultural Health at Universidad del Desarrollo. Dear Francisca, as you already know, you have around 5 minutes to share your ideas and comments around these two presentations. And the screen is all yours. Thank you.
Thank you very much, Baltika, for inviting me to participate in this webinar and for the two presentations, which encourage us to consider an issue that has become very important for global public health. So I took some notes, and I want to highlight that what these presentations show is that migrants and refugees face barriers that are not only logistical, but also deeply social and structural. So these barriers go from a lack of knowledge about how the health system works to experiences of discrimination and xenophobia, which undermines trust in institutions, which I think is a very important aspect. Secondly, both presentations remind us that vaccination is a social and a political act as well as a biomedical one. So trust in vaccines is built through daily interaction with healthcare systems and teams, and the experience of being treated well or poorly, and also the circulation of the narratives via social media and communities. Here, the qualitative study in Chile shows us how the pandemic amplified doubts and questions that now extend to other vaccination programs, and how these doubts intersect also with perceptions of migration, disease, and stigmatization. Ultimately, I believe that these studies offer insights that transcend the particular situations in Chile and New Zealand, and they demonstrate that the challenges of vaccinating migrants highlight wider issues, such as how to develop health systems that recognize diversity and mobility, and that avoid perpetuating social inequalities. Also, I would like to add that in the face of the mistrust and misinformation, promotion and education must be reinforced as a fundamental element that, as Nadia remarked in her presentation, should be worked in a collective way with communities. Thank you very much.
Thank you, dear friend, for your comments, especially on the emphasis on structural contextual elements, generating sometimes administrative, language, and also cultural barriers to access and uptake on immunization, as well as intercultural understandings and challenges around hesitancy to vaccination across New Zealand and Chile. Thank you so much for those insights. So I will now invite Dr. Rima Bass to the screen. She's a research associate at the Faculty of Health and Environmental Sciences Auckland University of Technology based in Auckland, New Zealand. Her research focuses on enhancing healthcare services during disasters, digital healthcare design, information systems for crisis management and response. She has worked with leading international humanitarian organizations, including the United Nations Office for the Coordination of Humanitarian Affairs and the International Committee of the Red Cross. Biorim, it's so wonderful to have you with us today. Please do share your thoughts and comments around this topic with us. Thank you.
Thank you very much for the introduction, Baltika, and thank you for inviting me to join this critical conversation on vaccine access and acceptance among migrant and refugee populations. This topic goes far beyond migrant health alone. It speaks to the design of resilient public health systems in increasingly mobile societies. So we all know that even small gaps in vaccination coverage can grow into broader public health emergencies. And it highlights the critical intersection of migration and public health. So I'd just like to share some reflections and insights into the fascinating presentations by Dr. Tarania and Dr. Obaj. So with Chile experiencing 105% increase in its migrant population and New Zealand navigating complex migration patterns, the shared question for both countries in the context of vaccine preventable disease would naturally be how to maintain robust immunization programs in increasingly diverse societies. So reflecting on both presentations, from Dr. Obat's presentation, it was clear that while migrants in Chile often report positive views of Chile's vaccination system, they still face significant barriers in accessing these very same services, which in my opinion suggests that the main challenge might not be really vaccine hesitancy, but rather structural barriers. And I really think that this distinction is important and has critical and profound policy implications. So thank you so much, Dr. Obach, for pinpointing this in your presentation. In this context, I'd like to draw the attention to some similarities between Chile and New Zealand. Both countries face the challenge of integrating diverse populations into their existing healthcare systems. And in both Chile and New Zealand, vaccine hesitancy affects native-born and migrant populations in similar ways, especially post-COVID. And also in both countries, healthcare workers continue to grapple with providing culturally competent care. These are just a few similarities, but there are also some contrasts between the two countries. For instance, Chile's reliance on physical vaccination cards rather than digital system creates challenges that New Zealand has largely avoided by investing in digital transformation. Whereas Chile's universal access model offers valuable lessons for inclusivity for Aotearoa New Zealand, particularly towards undocumented migrants. Now, both countries, like many others, lack robust systems for recognizing and transforming or transferring vaccination records across borders, which is quite understandable. So, for example, the story of Venezuelan mothers who lost their children's vaccination history illustrates how mobility can undermine continuity of care. So, looking ahead, I see opportunities for joining efforts and for joint research, including but not limited to conducting longitudinal studies that track migrant children's experiences, those who experience delays in vaccination. Also, systematic comparisons of vaccine policies across Pacific Rim countries, so Australia, New Zealand, Chile, and Canada, to help identify best practices. And certainly, given all the disruption that's going on around us these days, with all the technology and everything that's happening, certainly studies into digital transformation, including vaccination passports, cross-border health records, and so on. So finally, just a few takeaways for our audience. One, healthcare workers need training that goes beyond clinical skills. We need to address implicit bias, and we need to understand cultural humanity. Two, I think we need policies that reflect the reality of human mobility things like portable health records, recognition of foreign vaccination histories, and truly universal access that does not depend on documentation. Lastly, we should explore integration models beyond healthcare. This comes from design science, where I spend a lot of time. So we can learn from other sectors in multicultural societies that manage to provide services effectively. Finally, we all know that stakes are high in today's interconnected world. So the question isn't whether we can afford to include everyone in our health systems, it's whether we can afford not to. So these are some of the thoughts that I collected, and thank you for listening to me, and thank you.
Thank you, dear Reem, for those wonderful insights. I think you did a wonderful job in connecting points that weren't necessarily connected before and raising the main threads that are underlying between both presentations, as well as raising specific challenges that each country faces right now in the topic. So thank you so much for that. We will now move to our third and final panelist that will make also a 5 minutes presentation. His name is Dr. Jean-François Aguilera. He serves as a regional health specialist for the Americas, based at the International Organization for Migration Regional Office for the Americas and the Caribbean in Panama. His background is medical epidemiology with various experiences of projects development and implementation for different organizations and donors, NGOs, UN agencies, European Commission, private sector, and others, mainly in Africa, but also in Latin America and Europe. Dear Jean-François, it is lovely having you with us today. Thank you for your time and interest in sharing your thoughts, experiences as well, and understandings as a medical epidemiologist, but also as an IOM representative today for Latin America. Please go ahead, the screen is all yours.
Okay, thank you, Baltica. Muchas gracias. Good afternoon to everybody. And Baltica, thank you for, and colleagues, thank you for inviting me to this session, webinar. Yeah, as you have mentioned, my experience is more recently with migrants in Latin America and Caribbean. And it was, I mean, those two presentations from New Zealand and Chile were very interesting. And we have similar experiences. Well, Chile is part of a region where I'm in, and IOM is active in most countries in the region, and we have observed similar findings around the key barriers to access healthcare for irregular migrant population in the Americas. And similarly, consistently to what was presented, I will not focus only on vaccination, but access to primary healthcare services. So we have observed legal and administrative hurdles to access healthcare, lack of legal identity documentation, lack of coordinated processes between migration and health authorities, limited health insurance options for migrants, also language and social cultural differences, discrimination and stigma, especially those migrants from the LGBTQ plus communities and all people living with HIV, lack of trust in the health system that was observed with, in particular, fear of detention or deportation that could be felt by many migrants, and limited availability, accessibility to health service, along with financial constraints that migrants may experience. And finally, lack of information and awareness on how and where to access healthcare. Recently, in the context of forced returns, we observe there is evidence that this new context make irregular migrants even more vulnerable, with limited access to basic services, including healthcare, due to the reduction of donor support and situation that the migrant had not planned in their life. Specific population who are more vulnerable in our experience, I would like to mention migrant women, irregular migrant women who are facing barriers in accessing maternal and newborn health services, especially during transit or in detention, in a context of high gender-based violence exposure they are facing. And in particular, an overpopulation, LGBTQ plus migrants who are encountering systemic exclusion and limited access to care, and in particular HIV and AIDS care. Yeah, that would be my views and experience to share with the group. Thank you very much. Over to you.
Thank you, Jean-Francois, for your insights. I think the three panelists are very good at complementing and supporting the general ideas behind both presentations. So I thank you, all of you, for your great insights and support of this webinar. I think there is so much more that these presentations touch around contextual factors, structural factors, understandings, cultural differences, digital challenges, and how these experiences that are both in New Zealand and Chile also speak about other countries in both regions and other regions in the world as well. I will invite all panelists, Nadia, Alexandra, Reem, Francisca, and Jean-Francois, to now open your videos, your cameras, so that we can have final 10 minutes of Q&As, where we can discuss briefly, with 1 minute answers only if possible, a few questions around the topics that we have been discussing today. So just to start and open the floor, I would like to ask you, in your opinion and experience, what do you think are the top 2 to 3 urgent action points that should be addressed today in both countries to improve vaccination uptake among migrant populations? This could be based, of course, on the research that has been shared today in this webinar, but also based on your experience before. Who would like to start responding? I will repeat the question. In your opinion and experience, what are the top 2 to 3 urgent action points that should be addressed today in both countries to improve vaccination uptake among migrant populations? Dear Reem, please do go ahead.
In my opinion, I think it's a priority to invest in digital transformation, things like health information exchange, standardization of data, to be able to support the percentages of migration and the statistics that we've listened to during the presentation. So I think it's a priority. The technologies are there, and it's not a too much ambitious goal. So
Yes.
proper funding, adequate funding, and just targeted efforts would get us there.
Thank you so much, Reem. Nadia, what's your take on this?
I would say something that's going through us a lot in terms of the M space is that we have it as one of our national health targets, which in a sense is really great and promotes a lot of efforts in the immunization space. But us not reaching our target is an indicator of, let's say, a broken healthcare system. And sometimes focusing all of our efforts in these targets can kind of take the light away from really what needs to happen is more focus on building our healthcare system and also addressing the broader social determinants of health. My second thing would just be to support more local efforts. So it's really great to have these national coordinated responses, but we know how powerful our communities are. And we saw that during the COVID-19 response. So I'd love to see more support and funding for our local communities and providers to do what they do best because they know their communities the best. Thank you.
Wonderful, Nadia. That's a really take on improving and strengthening health systems as well as communities. Thank you so much for that. Dear Jean-Francois, please go ahead.
Yeah, thank you. I will focus on the South American context, which I know more. I don't know. I hope I will know more one day in New Zealand, but at the moment in South America, most South American countries, including Central America and Caribbean, have strong health systems in place. Most, I mean, some more, some less, but overall it's well developed and good health systems. Just they are often overwhelmed by migration flows. And where migrants are or are moving is not always where health services are available. So we found that many countries, even very developed or with good systems, have still gaps in areas where migrants are passing, where health systems are not available. So I think one priority would be to strengthen those health systems to match the needs of migrants where they are, in particular around borders. And my second priority would be to improve data collection, because often we don't have enough data to address the needs, to orient policies, or to facilitate political buy-in to strengthen the health system where they are needed. So data collection and health system strengthening where around border areas or at hotspots where migrants are passing or transiting over.
Thank you, Jean-François. Both are excellent comments that you're adding to the discussion. Thinking of migration as a process, as an active, dynamic thing, and not just thinking of providing services where healthcare systems and centers are, but more where migrants are. And that's quite a big change of focus on how health systems are often developed and designed. So that's a really, really good topic. And being a Latin American person myself as well, I completely agree that data collection and quality information is a big gap that we really need to strengthen, particularly among migrant communities. So thank you so much for those views. It's really interesting how each one of us can provide different views that complement each other and can produce like a 1-minute policy brief in a way through this webinar of point action. So fantastic. Dear Alexandra, please go ahead.
Well, thank you very much. And absolutely in line with all the comments of the colleagues. I think that they're absolutely adaptable to our own context of Latin America, as Jean-François is telling about, and so many similar challenges in New Zealand and here in Chile and also in Latin America in general. So thank you very much for your presentation, Nadia, and your comments, Green, Francisca, and Jean-François. I think that one issue that we have right now in Chile, and I think also in all Latin America and in America, but also in Europe and also in New Zealand and also in Africa, has to do with structural problems with the regularization of migrant communities. And this has a direct impact in immunization, and this also exacerbates a lot of xenophobia that we're living right now among migrant communities, and points them as responsible of some re-emerging disease. And this is also a political problem that we have right now, and also a social problem. And it also affects our public health, and it has to be with some political structural issues that we have worldwide right now, and we have to do something about it because it's affecting really hard in some communities. Thank you very much.
Alexandra, those are wonderful comments, are very strong, and they go to the backbone of migration processes themselves. And the idea of how irregular migration status is a health risk to communities and people. It's something that as a research center we have been saying for over 10 years now, but still migration policies are changing, are evolving, and political tension brings complexities to them. And so that's a very important point to raise, and to be aware of its effects on population health. It's very important in public health. So thank you so much for those comments. Fran, would you like to chip in and add something in the last minute we've got before we finish the webinar?
Yes, I agree with everything that has been said. So I will only add that I think that information is very key. The way we give the information and also to attack the misinformation that we have today, especially thinking in the context of Chile, where vaccination is more of an imposition from the Ministry of Health. And I don't know if people really understand why it is important. So beginning from that, and also information can also help to decrease xenophobia. So I would emphasize that.
Thank you, Fran. That's excellent. I fully agree with that point as well. Thank you, all of you, for this wonderful first webinar for this webinar series. To all of you listening to us today, thank you for joining. All attendees, welcome to this webinar series. Thank you for being with us today through this Zoom link or through the YouTube or UDD TV channel live streaming platforms. So just to close this webinar, I want to invite you all to our coming webinar, the second one, which is entitled Migrant Nutritional Health and Food Insecurity in New Zealand and Chile, Evidence-Based Lessons and Challenges. This will be happening on Tuesday, 14th of October at the same time in a different link, but similar to this Zoom seminar link. We hope we will have all of you and more joining to this webinar. Please register so that we can provide you the link. And thank you very much, all of you, for the pleasure of having you today. Have a great day. Goodbye.